So in this continuing mini lecture series of clinical snippet, today we will discuss one interesting class. In this interesting class we will discuss what are the cutaneous or dermatological manifestations of various cardiovascular disorders. So what are the various cardiovascular diseases or disorders, and what are their cutaneous manifestations, the correlations, rather cutaneous correlation of various cardiovascular disorders. So we will start one by one the various cutaneous disorders that can occur in a clinical examination we should look for, and these cutaneous presentations, if they are present, you should always rule out or think about some hidden cardiovascular conditions. There are very common symptoms which you already know, that we will just revise, and there are also atypical dermatological manifestations we should know, so that we will try to rule out hidden cardiovascular conditions. So we will start with the simplest and go through little bit complex dermatological manifestation. The first thing I will start with, everybody knows it, cyanosis. So the first dermatological manifestation will be cyanosis. So we know that cyanosis is, what is cyanosis? It is presence of reduced hemoglobin more than 5 gram%. If it is present, then the mucous membrane and tongue and all these things will appear bluish. So bluish discoloration of the skin and subcutaneous or the mucous membranes due to accumulation of reduced hemoglobin more than 5 gram%. We already know this. So if there is cyanosis, we will first think whether it is a central cyanosis. Central cyanosis. If it is a central cyanosis, we will see the mucous membrane, tongue, oral mucosa, everything will be blue. So the site of detecting central cyanosis is tongue and oral mucous membrane, they will appear blue. So if there is a central cyanosis, what are the cardiac anomalies? Congenital cyanotic heart diseases. First we will think of, like TOF, tetralogy of Fallot's, tricuspid atresia, dextrotransposition of great vessels, total anomalous pulmonary venous connections, persistent truncus, Epstein's anomaly. So all the congenital cyanotic heart diseases, most commonly TOF, which we will be coming, we may encounter in the adult medicine, little bit pediatric and adult overlap. Or the congenital cyanotic heart disease should be ruled out by echocardiography and all. Another thing, a left to right shunt like ASD, VSD, PDA, these left to right shunts, when they will cause pulmonary arterial hypertension, then this left to right shunt will get reversed because of increased pressure in the pulmonary artery. So these left to right shunts, after a period of time, because of hyperkinetic pulmonary artery circulation and development of pulmonary hypertension, these will reverse the shunt, and this shunt will now become right to left, which is known as Eisenmenger syndrome. So Eisenmengerization of the previously left to right shunt, so they become right to left, and there is cyanosis. So congenital cyanotic heart disease and Eisenmengerization of the left to right shunts, they will cause central cyanosis. Now cyanosis can be peripheral also. Peripheral cyanosis or acrocyanosis. That is, only the peripheries are blue. Extremities, they appear blue. Pinna appear blue. Ear lobule, blue. Tip of the nose appears blue. But the mucous membrane, oral mucous membrane, tongue and the mucous membrane, they will appear pink. So that is why it is acrocyanosis, peripheral digital cyanosis. That will indicate either our patient is in shock or the patient is in severe heart failure. leading to sympathetic overactivity. Sympathetic overactivity, as we know, severe heart failure will cause sympathetic overactivity and peripheral arteriolar constriction. So severe heart failure, there can be peripheral cyanosis. Shock, there will be peripheral cyanosis, and peripheral vascular diseases. So these will cause peripheral cyanosis. If there is a peripheral vascular disease, we will try to rule out hidden cardiological condition whether the peripheral vascular disease is atherosclerotic. So atherosclerotic association of heart conditions, or it can be collagen vascular disease or vasculitis, and we know that these collagen vascular disorders also separately affect the heart. Pericarditis, myocarditis, pericardial effusion, this can be association. So central cyanosis and peripheral cyanosis and heart disorders. Another thing is differential cyanosis. Differential cyanosis. So when we talk of differential cyanosis, so the upper limbs appear pink or normal, the lower limbs will be blue. So cyanosis is only present in the lower limbs, but the upper limbs are spared. This is known as differential cyanosis. So commonest cause of differential cyanosis is a patent ductus arteriosus with reversal of shunt. Reversal of shunt. PDA with reversal of shunt. We know that, again, engineering drawing, I am not going to the detailed anatomical drawing. Let us see what is a PDA. It is a persistent ductus arteriosus. We should naturally obliterate, but it is persisting. So what is this ductus arteriosus? It is connecting the pulmonary artery to aorta. We know that the branches of aorta, the last branch is the subclavian artery, left subclavian artery. So this abnormal connection is persisting, and this patent ductus arteriosus from the pulmonary trunk connecting to the aorta just distal to the origin of the left subclavian artery. So because it is attaching to the distal to the left subclavian artery, so the deoxygenated blood because of the reversal of shunt, is entering here and is causing lower limbs blue. Upper limbs are spared because it is distal to the subclavian artery. And subclavian and arch of aorta, other arteries are supplying to the upper limb. So this is a differential diagnosis of differential cyanosis. Second cause of a differential cyanosis can be this PDA. We add another anomaly, coarctation of aorta with PDA with reversal of shunt. Here the coarctation is also occurring distal to the subclavian artery, narrowing of the aorta, plus there is a PDA and there is a reversal of shunt. So you can get an association of coarctation of aorta also with PDA, and when this PDA will undergo Eisenmengerization, that will cause lower limb blue, upper limb pink. So differential cyanosis. PDA with reversal of shunt. Secondly, we should answer PDA with coarctation with reversal of shunt. Thirdly, it can be an interrupted aorta with PDA with reversal of shunt. Now second is reverse differential cyanosis. So differential cyanosis was lower limb blue, upper limb pink. In reverse differential cyanosis, upper limb blue, lower limb pink. So when there is a upper limb is cyanotic and lower limb is, there is no cyanosis in the lower limb. So in these scenarios, what are the things we should think of? A little bit complex. We will add transposition of great vessels. Transposition of great vessels. We know that transposition of great vessels means transposition of great vessels. Here the pulmonary trunk is arising from the left ventricle and the aorta is arising from the right ventricle. So when there is a transposition of great vessels, there can be reverse differential cyanosis. Second, transposition of great vessels plus coarctation of aorta plus PDA with reversal of shunt. This is another scenario where you will get reverse differential cyanosis. Another condition is supracardiac total anomalous pulmonary venous connections. So when the four pulmonary veins, they enter the left atrium, but in this situation the four pulmonary veins are not entering the left atrium, they are joining into the superior vena cava, which is supracardiac. Superior vena cava is supracardiac. In these situations, so you can also get reverse differential cyanosis. And lastly, there is an anomaly which is known as Telangiectasia or Telangiectatic spots. So what are these Telangiectasia? They are subcutaneous dilatation of the blood vessels. So the subcutaneous blood vessels are dilating. They appear like spider nevi. When you pinch this, they blanch. When you pinch this, they blanch. If some subcutaneous bleeding or something, had it been a subcutaneous bleeding, if you pinch, there is no blanching. That is why it is known as petechiae. So what is the difference between telangiectasia and petechiae? These are subcutaneous blood vessel dilatation, so that the superadded skin becomes red or pinkish appearance or reddish appearance, flushing, reddish appearance. And when you press it, they blanch. So telangiectatic spots and cardiovascular disease. So actually here, sometimes if these telangiectatic spots are overwhelmingly present on the face, that is present on the lips, tongue, oral mucous membranes, face, body. So overwhelmingly presence of telangiectasia, one should suspect of a syndrome which is known as Osler-Weber-Rendu disease. And usually in this Osler-Weber-Rendu disease, we should always auscultate the lung. Is there a presence of continuous murmur? Presence of a continuous murmur in Osler-Weber-Rendu disease, where there is overwhelming presence of telangiectatic spots. There is presence of a pulmonary arteriovenous fistula. This pulmonary arteriovenous fistula is causing a continuous murmur on auscultation of the lungs. So this is a situation where the murmur is coming on the lungs. So what is this arteriovenous fistula will lead to? It will lead to heart failure. These patients can also present with heart failure signs. Raised JVP, congestive cardiac failure, left-sided heart failure. So high output heart failure due to persistence of a pulmonary AV fistula. So one is Osler-Weber-Rendu syndrome. Second is telangiectasia of the malar area. Telangiectasia of the malar area of the face. Telangiectasia of the malar area of the face. Severe mitral stenosis. Severe MS. That is why it is known as mitral flush or malar flush in severe MS. Okay, it is not malar rash. It is a telangiectasia of the malar area, severe MS or scleroderma. In these patients, if there is no mitral murmur, try to pinch the face, skin of the face. Try to pinch the digits. So there is presence of scleroderma, inability to pinch the skin over the face, and there is associated cardiac anomalies. So scleroderma can present as pericarditis, pericardial effusion, valvular heart disorders, degenerative valvular heart disease, pulmonary stenosis. These can be present. So next we will be discussing about the cutaneous manifestations if there is hyperlipidemia. Hyperlipidemia. So what are the cutaneous associations? First will be xanthelasma and xanthomas. So xanthelasmas are lipid deposits in form of plaques in the inner or outer canthus of the eyes. So there will be yellowish raised small plaques, yellowish discoloration, and they are lipid deposits. Once these are there, one can think these are known as xanthelasmas, and one should think of hyperlipidemic conditions. Xanthomas are nodular eruptions. Xanthomas are nodular lipemic eruptions. Small, again yellowish discoloration, small nodular deposits. They appear in crops, and usually they are seen in the legs, thighs, buttocks, shoulders. Okay, so arms. So when these kind of lipemic eruptions are there, those are known as eruptive xanthomas. Eruptive xanthomas. Another type of xanthomas are known as tendinous xanthomas. As the name suggests, tendinous xanthoma, though these xanthomas are little bit bigger than the small eruptive xanthomas, and they especially occur in the extensor surface of the extremities and in the tendons. So Achilles tendon, extensor surface of the arms, when you palpate, you will get tendinous xanthomatous eruptions or xanthomas. They are little bit bigger. They resemble nodules. So xanthomatous, tendinous xanthomatous nodules, eruptive xanthomas, especially these eruptive xanthomas, they usually are very specific in hypertriglyceridemia and hyperchylomicronemia. So whenever there is increased triglycerides and chylomicrons, they usually present as eruptive xanthomas. Other dyslipidemias can present as xanthelasma, tendinous xanthomas. And another specific type of xanthomas which are known as palmar creased xanthomas. They specifically occur in the hands. Nodular eruptions, they occur in the palmar creases and on the hands. So when these are present, very specific, they represent type 3 hyperlipoproteinemia. Type 3 hyperlipoproteinemia, they will have palmar creased xanthomas, nodular eruptions on the palm. They are lipidemic eruptions. In these cases, especially in hyperchylomicronemia and hypertriglyceridemia, where there is eruptive xanthomas, so increased TG, eruptive xanthoma. Look at the fundus. Lipemia retinalis. So in this condition, when you look at the fundus, you will see there are the blood vessels. The blood vessels in the fundus, they are chalky white, milky white discoloration of the blood vessels. Milky white blood vessels. And the fundus is of a typical color, that is salmon color fundus. So this is, what about all the hyperlipidemic disorders, cutaneous manifestations of hyperlipidemia? And it is easy, whenever there is a hyperlipidemia, there is atherosclerosis, there is coronary artery disease. So cutaneous manifestation, any form of dyslipidemia, cutaneous manifestation, coronary artery disease, atherosclerosis. Here, one specific disorder requires a specific mention. It is known as pseudoxanthoma elasticum. So this is a specific disorder which causes premature atherosclerosis. Premature atherosclerosis. Atherosclerotic process accelerates from the age of 20, 30, and these persons, they develop premature atherosclerosis and coronary artery disease. Okay, so this pseudoxanthoma elasticum, what is the clinical manifestation, dermatological manifestation? The specific areas like in the neck, axilla, the intertriginous areas, axilla, groin, neck, the skin becomes extremely thickened, hyperkeratotic, cobblestone appearance, extremely thickened skin, they just dangle around like cobblestones, leathery, and the books have been describing this type of lesions like if you see plucked chicken appearance, plucked chicken. When we dress the chicken, the appearance of the skin of the chicken after the dressing, that is that leathery, thickened, hyperkeratotic, dangling in the neck, intertriginous area, that is the dermatological presentation of pseudoxanthoma elasticum. Okay, the skin of these areas look like plucked chicken. So, what are the cardiovascular association? Again, already we have told you that is premature atherosclerosis. Obviously, this person, young person, may have coronary artery disease. Apart from this, pseudoxanthoma elasticum is also associated with other cardiovascular manifestations like restrictive cardiomyopathies, mitral valve disease, especially prolapse, mitral valve prolapse. So restrictive cardiomyopathy, mitral valve prolapse, and rarely hypertrophic obstructive cardiomyopathies. So pseudoxanthoma elasticum, premature atherosclerosis, coronary artery disease, and other cardiovascular hidden manifestations could be there associated with pseudoxanthoma elasticum. So this ends with the lipid part. Now coming to the next dermatological lesion, lentiginous. So what are lentiginous or lentiginosis? Lentiginous are, these are small black colored, less than 0.5 centimeter diameter, black colored macules. These macules can have irregular borders. These macules appear on the skin or on the whole body. These are known as lentiginosis. Especially they aggravate with exposure to sun. And these lentiginous, they are associated with some complexes. There are multiple syndromic involvement. We will be not just discussing every syndromic involvement. We will just involve lentiginosis. If you see lentiginous, what cardiovascular things one should keep in mind? One is Carney's complex. And one should think of this Carney's syndrome or Carney's complex. What is this? Along with lentiginosis, you will get arterial myxomas. Multiple arterial myxoma, multiple subcutaneous myxomas, lentiginous arterial myxomas. Second, along with lentiginosis, another syndrome, Leopard syndrome. So what is the syndrome? That is L stand for lentiginosis, E stand for ECG abnormalities. So once we say ECG abnormalities, we are talking of arrhythmias. So this person, lentiginosis, if having Leopard syndrome, he will be having arrhythmias, VTACs, VFibs, PSVTs. So a lot of arrhythmias are associated with this. Ocular manifestations, hypertelorism, ocular hypertelorism. P for pulmonary stenosis. Here altered genitals, growth retardation, and deafness. Usually sensory neural hearing deafness. So we are not going to discuss what is our purpose of this class is lentiginosis can be associated with arterial myxomas, Carney's complex, lentiginosis, pulmonary stenosis, ECG rhythm abnormalities, Leopard syndrome. So this is what dermatological manifestation of atrial myxomas and different syndromes in lentiginous, if you find lentiginous. Then acanthosis nigricans. If I talk of acanthosis nigricans, what is it? Hyperkeratotic, velvety, blackish, bluish, velvet color, thickening of what? Of especially nape of the neck, skin on the nape of the neck or anterior part of the neck, and again intertriginous area. Like axilla, groin. So supremely, extremely black, hyperkeratotic, velvety, thickening of the skin. That is acanthosis nigricans. Usually when you talk of cardiovascular conditions, acanthosis nigricans is equal to metabolic syndrome, is equal to obesity. Metabolic syndrome, obesity, coronary artery disease, atherosclerosis, coronary artery disease, metabolic syndrome, obesity. Though acanthosis nigricans also, all these things are interrelated. Insulin resistance, diabetes mellitus, they all play together. So this is a marker of abnormal metabolic syndrome. These things can have hypertension, dyslipidemia, insulin resistance, coronary artery disease. So acanthosis nigricans. Though acanthosis nigricans is also being blamed notoriously with as a paraneoplastic dermatological manifestation of GI malignancy, but commonly acanthosis nigricans is equal to cardiovascular anomalies, what we talk of. Another thing is earlobe crease, Frank sign. A lot of studies has been done on this, especially in the earlobe. There is a transverse crease. If there is a transverse crease in the earlobe, studies have found that most of these patients have coronary artery disease. So as a marker of atherosclerosis, xanthoma, xanthelasma, earlobe crease, acanthosis nigricans, these can be the hallmark clinical signs, dermatological signs of coronary artery disease. So this is one is Frank sign or earlobe crease. Now another thing is hemochromatosis. So abnormal iron metabolism, excessive of increased ferritin, excessive of iron, and these irons are deposited in the heart. Will cause heart failure, especially restrictive cardiomyopathy. So restrictive cardiomyopathy, heart failure, because iron is getting deposited in the heart. Along with it, iron gets deposited in the liver, cirrhosis of liver, iron deposited in the brain, hypogonadotrophic hypogonadism, hypogonadotrophic hypogonadism because accumulation in the brain, pancreas, diabetes mellitus, and skin. Hemochromatosis patients, ferritin stimulates formation of melalin, and this melanin is deposited on the skin, and the skin is bronze in color. Bronzing of the skin, as if like bronze. Color of the skin is bronze. So sometimes it is known as bronze diabetes. Sometimes it is known as bronze diabetes. And this failure, look at the JVP. Bronzing of the skin, look at the JVP. JVP is raised. Patient is in heart failure. Get an echo done or MRI done. Restrictive cardiomyopathy. So bronzing of skin and heart failure. Hemochromatosis. Again, a granulomatous disorder, sarcoidosis. Non-caseous granulomas, multi-system involvement. Usually affects young persons, usually females. Immunologically mediated, granulomatous condition. What are the dermatological manifestations and serious manifestations? The dermatological manifestations of sarcoidosis is lupus pernio. Especially in the cheeks and the nose. Cheeks, nose. There are pinkish plaques. So in the nose area, in the cheek area, there is the rash distribution of pinkish plaques. That is known as lupus pernio. Lupus pernio. Granulomatous skin reaction. Second is erythema nodosum. So especially in the legs, in the shin of tibia, bilaterally symmetrical in the leg area, especially in the anterior part of the neck, of the legs, you will see raised, tender nodules, large nodules, slightly raised from the skin, tender, large nodules, from few centimeters to, say for example, this can be from 3 to 4 centimeters to 20 centimeters. Elongated, erythematous, raised, tender nodules, erythema nodosum, also known as paniculitis, inflammation, erythema nodosum, sarcoidosis. So when lupus pernio, erythema nodosum, sarcoidosis, heart, restrictive cardiomyopathy. And most important, arrhythmias. Especially complete heart block, retacks. So in a young person presenting with complete heart block, acquired complete heart block, young person, arrhythmias like VTAC, think of sarcoidosis. MRI should be done, sarcoidosis should be ruled out. And if present with classical dermatological manifestations, lupus pernio, erythema nodosum should be searched. And if at all these are present, this should be searched. Complete heart block is association. So this is sarcoidosis. Palmoplantar hyperkeratosis. In these patients, the palms and soles, sole of the feet and palm. So palmoplantar, extremely hyperkeratotic thickening of the skin of the, especially in the palms and soles. Look at their ragged, thickened, thick skin in the palms and soles. This is known as palmoplantar hyperkeratosis. And if this is present, what are the cardiac anomalies? Knox's syndrome and Cardiovascular syndrome. So Knox's syndrome and Cardiovascular syndrome are the two conditions where we get palmoplantar hyperkeratosis. These persons, these are usually pediatric age group. They have hair, woolly hair, like wools, soft, woolly hair, palmoplantar hyperkeratosis, and this Knox's syndrome variant will present as arrhythmogenic right ventricular cardiomyopathy. Arrhythmogenic right ventricular cardiomyopathy. These young subjects may present as malignant ventricular tachycardia, sudden cardiac death. So, cardiomyopathy, right ventricular cardiomyopathy, Knox's syndrome, woolly hair, palmoplantar hyperkeratosis, arrhythmias, MRI, there is the right ventricular chamber is being replaced by smooth muscle tissues. There is no cardiac muscle, fatty deposits, arrhythmias. Second, Cardiovascular syndrome, left ventricular cardiomyopathy, heart failure. So dilated cardiomyopathy, heart failure, arrhythmogenic right ventricular cardiomyopathy. So palmoplantar hyperkeratosis, dermatological manifestations of these two syndromes, Knox's and Cardiovascular syndrome. Cephalic spots. Cephalic spots. So brownish macules over the body, thighs, trunk, back. There are brownish macules. If a macule more than 1.6 centimeter in diameter and more than 6 macules are found, then one should think of underlying pathologies, especially neurofibromatosis 1. So cephalic macules is equal to neurofibromatosis. And what can be the hidden cardiological manifestations of neurofibromatosis? Any mitral valve disease, MR, AR, endocardial cushion defects, VSD, ASD, anything. They can be having neurofibromatosis 1, cardiovascular manifestations. What in the skin? Cephalic macules. So in a nutshell, these are various dermatological manifestations of cardiovascular conditions. The only take-home message is, while in the bedside clinic, if one should in a clinical examination search for dermatological lesions, and if you encounter one of these dermatological lesions, some are very obvious, heart failure, other conditions, and should be correlated, and especially difficult situations or atypical dermatological signs, one should look for associated heart disorders. Thank you.